So a little bit of history. Hypothesis on pathogenesis was initially given by Gas, who actually with a 90D examination almost told us what we know with an OCT right now. It was really great effort. Kelly and Wendell, vitrectomy with induction of PVD, initially in 1990s, and internal limiting membrane came in later in 1994, and OCT came in at 2000 so that we could objectively assess the results of our surgical procedures. Etiologically, most common that we all see all the time is idiopathic, but you can see traumatic macular holes and macular holes in high myopia, maybe macular holes with retinal detachments, etc. So very rare causes would be scleral buckling for retinal detachment, pneumatic retinopexy sometimes can cause it, after choroidal neovascularization, even in proliferative diabetic retinopathy, Best's disease, adult vitiliform macular degeneration, etc. So a clinical diagnosis, basically a macular hole can be picked up with an indirect ophthalmoscope or a direct, but a Watzke-Allen test where you are basically putting a very strong small slit beam and moving across the hole. It is a subjective test where the patient immediately tells that there is a defect in the light, or maybe you can also do a laser point test where with an aiming beam you can show into the macular hole and the patient will not appreciate it. But OCT is a gold standard in the diagnosis of macular hole, and it is better than biomicroscopy. It is objective, high myopia and posterior staphyloma. OCT has its advantage significantly. Now, stage 1 is when there is a perifoveal detachment of the posterior hyaloid, and anteroposterior traction is there, but many of the stage 1s may close on its own, or it may not progress, and that is why many people would not consider doing any surgery in stage 1. But when there is a separation of that inner layer, then you have a lamellar separation, which is in a stage 2. Usually it's less than 400 microns. And then we have a PVD induction, which is starting to occur, but there will be some attachment in stage 3. And if there is total PVD induction with a large hole, then it is stage 4. Natural course is stage 1 hole with less visual acuity has a higher risk of progression. 85% of stage 2 holes and 55% of stage 3 holes significantly progressed, and 16% of stage 4 holes enlarged, and the final visual acuity will be somewhere around 3/60. So generally in stage 2, 3, 4 in idiopathic macular hole, you would consider surgery, or if there is a decrease of vision, or if there is a recurrence. Traumatic holes, you may wait for the first 3 to 4 months because some of these traumatic holes show spontaneous resolution. Myopic macular holes often require surgery. And visual acuity, there is no gross visual acuity cutoff, but it all depends upon each individual surgeon. So if you have done an audit of your own clinical surgical success, and if you are able to give in 6/9 or 6/6 parts, if you're able to consistently close the holes with good visual recovery, then you are justified in doing that. Macular hole size, macular hole forming factor, etc. are also important. So this is a small, the surgical steps would be core vitrectomy. I usually use triamcinolone assisted PVD induction and ILM removal, a fluid air exchange, and we completely remove the fluid from the surface, and an air C3F8 or an SF6 exchange is already done, also done. So this is a small surgery where we are showing macular hole. This is a 25 gauge. Generally in macular surgery, you can either use 25 or 27 gauge surgery because it is very limited. This is 27 gauge. You should understand that this is always valved cannula always. And so if you have to inject something, you have to put in a vent on the other side. PVD induction is usually triamcinolone assisted, and usually we will start doing from the disc, and just with the suction you can take it out. And when something's like this, so you basically use your traction away from the macula to bring the vase ring out. And when you are inducing that PVD on top of the macula, make sure that you are not pulling on the macular hole because you may tear it. So sometimes you should use a forceps, or you can also use a silicone tip to induce PVD, which is very atraumatic also. Once PVD is induced, probably there will be some residual triamcinolone left, and sometimes if your ILM visibility is quite good, then you can, especially in a very clear media or a pseudophakic media, probably you can do an ILM peeling with a pinch and peel technique. I do not use usually a membrane scraper or a sharp instrument to take this. Sometimes there are some petechial hemorrhages around which will clear by day one. So this is a pinch and peel technique where you have that initial pinch, and with that pinch itself, if you are able to get the ILM out, it is very good. But nowadays, generally everybody uses brilliant blue-green. So if we are using brilliant blue-green, the ILM also becomes a little edematous, and it is a little easier to separate the ILM from the retina. So the pinch and peel technique works quite well with the brilliant blue. Like this is the brilliant blue injection. Your care should be taken not to inject this a big jet into the hole or into the disc. You usually inject it into the supranasal quadrant, and once everything is clear, you can see the contrast which is coming on very nicely. So this is initial lift up of the ILM, and from there you can remove it. Slowly you can remove it. Now we have the ILM flaps for larger holes. Now this ILM we will remove across the macular hole so that it is a complete removal. And in smaller holes, definitely more than 90-95% hole closure rate is there with just ILM removal. But with larger holes, just with this technique, the macular hole closure rate is not as good. So when you have larger holes, generally what I use is an ILM flap, where till the edge of the hole we will peel the ILM, and then we will insert that ILM right into the macular hole. Only thing is that if there is a detachment of that ILM flap, probably you can take another ILM from some area and then insert it. And care should be taken while you are doing an air fluid exchange, because when you are doing an air fluid exchange, this can dislocate. So you initially keep your silicone tip away from that central area, fill in air, and then somewhere in the nasal area undo. So macular surgery is always so special. Internal limiting membrane removal, 95% hole closure rate with ILM peeling. Probability of macular closure increases about 2.5 times and 3.1 times in holes less than 6 months, 5 times for stage 2 holes. So factors determining the final visual acuity, the functional and the anatomical visual outcome, would be duration of symptoms, the most important. If it's a very old macular hole, the results are not very good. The size of the hole is very important, but definitely with ILM flap, most of the large holes, all the large holes probably till this point of time have closed. The anatomical improvement is also having some functional improvement as well, not as much with the smaller holes. The hole forming factor, the ISOS junction integrity, and the ELM are very important. Indocyanine green is not at all used now because of toxicity. Prawn positioning, there are different authors who have basically said that prawn positioning may not be needed. Maybe a limited prawn positioning, maybe for the first 2 or 3 days, can actually close. Type 1 closure is having very good results, and type 2 is the more V-shaped closure with larger holes. There are quite a lot of complications, including the RP changes where you have pinched, maybe you have damaged a little bit of the retina around that macula, and so we cannot pinch from the papillomacular bundle, pinch it away, and then from there you come down. Progression of cataract, nuclear sclerosis will occur, secondary glaucoma can occur, especially in persons who are having responders to steroids. Retinal breaks, retinal detachments can all, so at the end of surgery you have to definitely go to the periphery, screen for any tears or breaks. What is new? 27 gauge, case selection based on OCT findings, and customized ILM peeling for larger holes, probably larger peels, and for smaller holes, smaller peels, etc. Flaps whenever is required, etc. So thank you.